We're going to do both sides of this. I think you may get the sense that from our Department of Thoracic Surgery at Mount Sinai, we may be in the philosophical group called the skeptics. But as a robotic surgeon myself, sometimes we have to ask the question, while we agree that the technology is fantastic and allows us to do technically difficult operations, what's the current state of evidence supporting the role of robotic-assisted surgery? And in this particular talk, I'll go over the data that either supports or doesn't support the use of robotic-assisted lobectomy versus VATS-assisted lobectomy. I'd like to thank college student Sophia Miller, who helped source some of the evidence and also create some of the slides. As a disclosure, I do serve as a surgical proctor for Intuitive, the company that makes the Da Vinci system. So what that means is that I train other surgeons on the robotic platform. As Dr. Veronese alluded to, the two main minimally invasive platforms that we have available to us to perform thoracic surgery would be the robot-assisted technology that currently is dominated by the Da Vinci platform. We've seen advancements in that platform from an older model to the newer SI model, which is currently a four-arm technique, which you see here on the left. You see 4 separate port sites. Most people add an additional manual port site for the passage of sponges and so on and so forth. And all 4 of these robotic arms are controlled on the console that Dr. Veronese showed with the dual console side by side. The standard for video-assisted thoracoscopic surgery, which is the way that, for instance, I was trained to do lobectomy, falls under a Cal B 39802 consensus technique, which includes a 4 centimeter or less utility incision that has no rib spreading, and then 2 additional port sites, 1 for a camera and 1 for a posterior retractor or tool to use, instrument to use during the operation. So this talk will go over the current evidence of either one of these techniques for lobectomy, not for segmentectomy. So the way we constructed this talk was to look at 3 basic zones or buckets of information. And I think this is a way that we could either justify or not justify the use of robotic-assisted technology. One is obviously the perioperative and short-term outcomes. What are the long-term outcomes and recurrence rates after robotic or video-assisted technology? And then what's the cost effectiveness? I think these are the 3 main categories that would help inform our decision whether we should continue to use or whether we should adopt robotic-assisted surgery for lobectomy. So what we did is we tried to compile the strongest evidence, the most up-to-date studies that looked at this question of robotic-assisted versus video-assisted lobectomy. And one of the more recent large multi-institutional retrospective studies was called the Portal Study. This was basically the work of Mike Kent up in Boston, along with many other surgeons throughout the United States who are all avid robotic surgeons. In total, there were 5,721 cases that were reviewed. This is a retrospective data analysis from 21 institutions. There was a 7-year period where data was collected, 2013 through 2019. All cases were considered early, quote unquote, operable stages, stage 1A to stage 3A. And then patients were taken and propensity matched in a 1-to-1 matching process to decrease bias. As you can see from their results, the conversion rate from overall comparing both groups was significantly less in the robot assisted technique compared to the VATS technique. And when they looked at conversion by stage, they saw that there was a lower conversion rate for robotic surgery across every stage through the study compared to VATS. And the reasons for conversion were similar for both, with no significant difference in that most of them were elective conversions, with very few cases converted for emergent bleeding. Most importantly, when we look at their short-term outcomes, comparing the robot-assisted technique versus the VATS technique with 1,700 patients in each group, the overall complication profile was insignificantly different between the two cohorts. So overall, there are about 27% complication rate in the robotic and 30% in the VATS. Most of the complications were pulmonary in nature, which mimics what we've seen historically throughout surgical resection. This is traditionally the most common complication related to open lobectomy as well. Cardiac complications occurred in roughly 10% in both groups, and that usually would be atrial fibrillation. And then we have various other smaller complications with no other significant difference. What was more significant, highlighted in red, is the postoperative blood transfusion was significantly less in the robotic arm, which I think mimics what most robotic surgeons would see, which is a significantly less estimated blood loss per case. You know, at our institution, average blood loss for a thoracoscopic or VATS lobectomy would probably be about 200 to 250 cc's, still not requiring a transfusion, but with a robotic approach, we're down to about 25 cc's per case. In terms of quality of life, which Dr. Veronese had alluded to, chest tube duration is shorter in robotic cases, which ultimately leads to a shorter length of stay, with a median length of stay of 3 days compared to 4, which is a significant cost savings and quality of life metric for lobectomy. Now, the Portal study was not randomized. The largest randomized recent study we could find was published by a group from Shanghai at the Jiaotong University. And I always laugh when I see that name because I don't know if there's anybody from China in the audience, but Jiaotong University means traffic university. So why the traffic university has one of the best world-class university hospitals, it's still an enigma to me, but the name of the university translates as the Traffic University. So in this randomized study, eligible patients were 18 years or older. Everybody was able to tolerate a lobectomy. Patients were randomized to RATS or VATS in a 1-to-1 ratio. Everything was done with a standard surgical approach, and all surgeries were performed by the same group at the hospital. As you can see, there was a significant difference in blood loss. There must be a typo here because they said that it was about 100 milliliters in both groups with a p-value of 0.04. So I'm assuming that the video-assisted number was supposed to be higher. But most importantly, when you look at cost here, there was a significant about $4,000 to $5,000 increase in direct and indirect costs for the robotic technique, with all other complications and perioperative outcomes being indistinguishable between the two groups. So in one of the largest randomized controlled trials, we show that there's no superiority or inferiority for the robotic approach compared to the VATS approach. So when we look at the two most recent, largest, highest quality papers regarding perioperative short-term outcomes, we really don't see any superiority or inferiority for the robotic approach versus the thoracoscopic approach. And so the next logical question is, do we see overall an oncologic difference or a long-term outcome difference between the two techniques? Bernie Park, and I don't even know if he still uses that utility incision approach. I think most robotic surgeons have switched to just a pure portal technique. But Bernie Park and a group also in China, the Sun Yat-sen University, did a retrospective analysis of the long-term outcomes for early clinical stage 1 non-small cell lung cancer in robotic versus thoracoscopic surgery. All of this data comes from the Memorial Sloan Kettering prospective database, which from my personal knowledge is a really wonderful, well-maintained database, which has no issues with their data accrual at all. And again, when you look at the perioperative outcome, the most significant differences are seen in length of stay. So the average is 4 days for minimally invasive and 5 days for open. As Dr. Veronese alluded to, there was a significant increase in the number of average nodes sampled, with 5 nodes for the robotic approach, 3 nodes for thoracoscopic, and 4 nodes for open. But otherwise, there were no real differences between the groups. When they looked specifically at overall survival and disease-free survival, and I apologize that it's unclear which one's overall, on the left-hand side of the screen is the overall survival, on the right-hand side is disease-free survival. Overall survival was defined as time from surgery until death, and disease-free was time from surgery until recurrence or death from any cause. The median patient follow-up was 53 months in the VATS and 40 months in the robotic technique. If you look at the curve, the Kaplan-Meier estimate on the left side, the 5-year overall survival for open was 78%, for VAT 73.5%, and robotics 78%, with no significant difference in survival between the 3 cohorts. And also similarly in the disease-free survival analysis, there was no significant difference. So overall in their large retrospective analysis, there was no survival difference, either inferiority or superiority for robotic approach versus video assisted, with minor differences in lymph node sampling and length of stay. Subroto Paul, who used to be with Nasser Al-Turki's group at Cornell and who's now at the Barnabas Health System in New Jersey, also performed a large retrospective analysis of the SEER Medicare data. So SEER Medicare data is a large multi-state database. When it's combined with Medicare, we get very distinct outcomes data and mortality data, but it only includes patients who are 65 years and older. So this is a longitudinal SEER Medicare data set with 65 plus age patients. Data was accrued over a 6-year period, 2008 to 2013, and patients were then propensity matched in a 1-to-1 analysis, and they compared overall survival and cancer-specific survival over a 6-year period. What they found that there were 3,881 VATS cases and 426 robotic cases. And then when they propensity matched them, there were 409 patients in each group. The median age of surgery was 73. All patients had a single lobectomy without any additional surgery, so no chest wall resection, no additional wedge resection. So these were straight up lobectomies. Overall survival, as you see on the left-hand side, at 3 years, which was death or loss to follow-up, showed a 71% survival for VATS and a 73% survival for robotics. The cancer-specific mortality at 3 years, seen on the right, showed a 17% cancer-specific mortality risk for the VATS group and 15% for the robotic group. None of these curves differed in any significant way. So again, the conclusion was that there's no significant difference between perioperative complications or mortality between robotic and thoracoscopic approaches. And finally, our sort of last criteria, if we're doing a scorecard on should we do robotics versus VATS, is, well, what's the cost? What's the cost both to the healthcare system and what's the cost to society? So Ben Kozauer at WashU Washington University in St. Louis was able to model a healthcare cost analysis of robotic surgery versus thoracoscopic surgery. And fundamentally, they found that on average, there's about a $400 healthcare cost difference per case for robotic lobectomy, whereas the societal cost, which takes into account the quality of life measures such as length of stay, return to work, pain loss, so on and so forth, reduces that cost difference to about $247 per case. And what they did in a type of analysis that I'm not sure is facile to most of us, was they're able to look at what that rate of dollar amount per quality life year would be and how that compares to what someone would be willing to pay, and the cost difference of $180,000 per quality life year adjusted versus $113,000 in societal perspective really shows that the cost related to providing benefit from robotic surgery compared to VATS is quite significant. The common cutoff for a willingness to pay or WTP model would be about $50,000. So at the lower end of a WTP analysis, RATS would fail a cost efficiency analysis, but at higher costs, it does satisfy that analysis. And interestingly, when they looked at proportion of cases that were planned to be done thoracoscopically, to get to that WTP or the willingness to pay rate of $50,000 per quality adjusted life year, if you could carry out 73% of your planned operative cases robotically, you would bring your efficiency down to an acceptable $50,000 cutoff. So in conclusion, when we look at the current state of affairs, the short-term outcomes show that there's really no superiority or inferiority for robotics versus VATS. When we look at the long-term outcomes, there's no superiority or inferiority associated with robotic versus VATS. And in the cost comparison, there's definitely no superiority. There could be slight inferiority. So overall, why would we do robotics? And I think it's the same issues that Dr. Veronese brought up, is that what's not being studied in these randomized or retrospective studies. And it really comes down to what's the complexity of the resection being done versus standard resections. Are we doing things like bronchoplasties, segmentectomies, extended resections that include the chest wall or pericardium, or in Dr. Veronese's case, a robotic pneumonectomy? Are we doing more neoadjuvant immunotherapy or neoadjuvant chemotherapy cases in a minimally invasive way with the robotic platform? And I think there's also data that's incredibly important, not for a quality of life to the patient, but a quality of life to the surgeon, is what are the ergonomics for robotics versus VATS? What's the risk of surgeon injury over time? These are very complex operations. Even a simple lobectomy is actually quite challenging when you do it robotically. It's a very powerful technique with a risk of significant injury. And is there any prolongation of a surgeon's career? We do have an enhanced visualization of 10 times magnification versus 4 times magnification with the robot. It completely eliminates tremor, and it allows us to do more complex wristed motion compared to VATS. And so these are all aspects that are not studied in database analysis. And ultimately, it comes down to the fact that, like any other technology, ultimately it's just another tool in our surgical toolkit. And I think you will continue to see, despite sort of equanimity between the data, more adoption and more use of the robotic platform. Thank you very much. I hope that that was an enjoyable review of the literature.
Well, those are two really wonderful talks for robotics. Do we have any questions, comments from the audience? Professor Granis.
And I'm an ex-smoker with 30-pack years, and I don't want to die of lung cancer.
Are you being screened?
But nobody at this meeting seems to be interested in screening people at age 80 and over, except Claudia and David, William Veronese, and Lori Fenton. So the question I have, and I think that's a form of elder abuse. I would like to ask the surgeons and radiation oncologists, if I walk into your office at age 85 or 90, and I remain in reasonably good health, except for some mild obesity, will you be able to offer me a safe and effective, potentially curative treatment at advanced age?
So,
Absolutely. I just did that
Andrew, did you hear that
operation.
question?
Yeah, 85 is the new 50. Yeah, we would definitely be able to offer you curative intense surgery. I just did that operation last Thursday. The guy did better than my 65-year-old.
David,
I don't,
are you going to continue on that?
I was
thread?
going to just say if there were any other, I mean, we have two radiotherapists who are in the room. I'm sure you guys have no problem doing treatments on a.
So I can say we can do much safer now with either SBRT or traditional conventionally fractionated radiation therapy. But I will back my decision on our common knowledge of what's better for the patient, and the patient also the patient's will.
By the way, you just saw the difference between a thoracic surgeon and a radiation oncologist.
Pulmonary function matters,
Thoracic
cardiovascular
surgeon was,
matters, and
I'm taking them right in, we're operating.
Ah.
And here the more, well, let's not say cerebral approach.
no, it all depends on location, size, and so on. It's not a straight
No,
answer.
they were not asking for a comparison of which one you might do. It's whether you would do any treatment at all. Yeah.
But you know what we would do, Fred? We will ask you in Gdańsk, when we discuss such a case, we discuss it together, and then you will visit first Rafał or first me and then me. And then you decide what you want.
Yeah, I think the point Fred was trying to bring out was that he would not be eligible to be screened, whereas ultimately what you're doing with screening is you're trying to get to a point where you would treat somebody, and clearly the radiation therapist would be willing to treat and the surgeons would be willing to treat. So why are they excluding these people from screening? Because the treatment is available. No, the treatment people are not concerned about this. They would easily want to treat a person that had cancer at that age. So why aren't we screening them? I think that's the main point. Professor Mulshine had a question.
Yeah, David, thank you. I think this is an important question, but the reality is, if screening picks up in the United States, Europe, Asia, we're going to run out of specialists to deliver care. And so the issue of the efficiency and the adequacy and the cost of these interventional procedures is really critical. But, methodology, I think, is still a problem. So the cost differential, how was that done relative to like days in hospital? How was the cost calculated for that? What was the cost estimate for transfusion dependency? Because, the transfusion dependency, there's a certain number of people that wind up with downstream consequences to the transfusion. And how is that costed into the thing? These things are small, but if we start thinking about going from 5%, 10%, penetration into the target population to 50, these are going to become really, really important. And the wear and tear on the thoracic surgeon is a big consideration. So I think that there should be a more concerted effort to say there's workforce considerations going forward that are going to be a big deal in allowing this to go forward in a thoughtful kind of way, an efficient way. And so I think this kind of discussion is really important.
Yeah, no, I'm glad you stressed that. Also, I'm glad that Andrew brought up the wear and tear on the surgeons and the advantage of the robotics and how it can extend their careers. Very important point. Raj, did you have a question?
How do hospital financials impact the use of robots? In the sense, kind of across institutions, a hospital invests in the robot and the upkeep and so on. Does that drive the use of the robot more?
I think in the United States, it's more of the tail wagging the dog. So you have both consumer-driven desire and surgeon-driven needs that usually sometimes are in concert with hospital administration. So, as Julia had on her slide deck, there's been a very rapid utilization increase in robotic thoracic surgery and all surgery compared to standard laparoscopic or thoracoscopic over the last few years. And there are significant costs associated with that. And the purchasing models will be different across each institution, but in the cost effectiveness analysis paper that I reviewed, they looked at both a societal cost benefit versus a healthcare cost benefit. So the healthcare cost is strictly what you're referring to, which is, what's the upfront cost for the technology and what's the contract cost for maintenance and training, and they're not insignificant. So there's about a $12,000 increase in the cost per case when it's not amortized over the number of cases you do. So the more utilization a hospital will have on their platform, the cheaper it becomes per case. But there still is a moderate or modest cost increase per case. But from a societal cost benefit analysis, because of the length of stay and complication profile is generally even better than standard thoracoscopic surgery, that cost evens out. But there's no denying that there's an increased cost to the healthcare economy with the use of robotics for sure.
Did you want to add something, Julia?
Just to add this kind of information, in our country, we have in the private system, the insurances have accepted to give more money according to the technique. So we can add the robotic cost to the budget of the procedure. On the contrary, the public system does not give any additional cost for robotic. But our experience in my previous hospital, where we analyzed the cost of the 3 procedure, robotic, VATS, and open, we could observe that around a 13% increase cost in robotic compared to VATS. However, we had still a sustainable procedure because the reimbursement of the public system covered the whole procedure, even in the robotic field. So for the hospital is a little bit less margin, however, still feasible.